Hi, good evening to all of you and a very warm welcome to the third session of the MUGIS 2021 Virtual Symposium. So I'm Kelvin Boon from Penang GH. And so today the theme will be on mainly management of complication after esophagogastrectomies. And also we have our head of service to talk about the upper GI services and training in Malaysia, as well as two of us will be sharing our fellowship experience abroad. So as usual, we have put together a very strong team of faculty for the show tonight. So with me, I have three panelists. I'm probably just going to introduce them one by one to you. So first, I have Mr. Lim Huai Chin, a consultant upper GI surgeon from Regency Medical Center, Johor Bahru. So Mr. Lim completed his upper GI training under the Ministry of Health program, and he spent 1 year in Taiwan and also Japan to complete his training in upper GI cancer as well as bariatric surgery. He was working in Hospital Sungai Buloh before he moved on to Johor Bahru. The second panelist we have today is Mr. Vijaya Shankar. Mr. Vijay is a very experienced surgeon previously based in Hospital Tuanku Jaafar for 6 years before he moved on to KPJ Seremban Specialist Center, and he's working there at the moment. So he also completed his upper GI training under the Ministry of Health program, and he went to both Singapore and India to further his training in both upper GI cancer as well as bariatric surgery. Last but not least, we have Mr. Yap Chilong, from consultant upper GI surgeon from Gleneagles KL Hospital. Mr. Yap had his formal training under UMMC before he spent 2 years in Royal Infirmary, Edinburgh, and returning as an upper GI surgeon and worked in UMMC before he moved to Gleneagles KL. So as usual, I'm just going to announce a few housekeeping rules before we start. Number one, you notice you have been muted upon entering the webinar. So if you have any questions or any opinions along the way, feel free to put up in the chat box or the Q&A function. We shall reserve all questions after all the presentations in the Q&A session. And second rules, of course, if you notice that this symposium is being recorded for both internal use and also for future replay, your participation certainly serve as a consent for us to record you down. Right. So without further ado, probably I should pass the stage to Mr. Lim Huai Chin to introduce the first speaker. Mr. Lim, the stage is yours.
Hi, good evening, everyone. To start off today, we have actually Ms. Hashima to talk to us on leak after esophagogastrectomy. What should we do? So a bit of introduction for Ms. Hashima. She is actually currently the head of upper GI surgical unit at Sarawak General Hospital under the Ministry of Health. Her main interests includes actually upper GI cancer surgery and clinical nutrition. She has been actively involved in training clinicians in the field of clinical nutrition under the Parenteral and Enteral Society Malaysia, and also the certified trainer for Aspen Lifelong Learning Program. She has been in MUGIS since 2013 and is a committee member in the National Upper GI Surgical Training Committee. Without further ado, I would like to pass the stage to Ms. Hashima.
Good evening, and thank you, Mr. Chairman, for your kind introduction. I would like to take this opportunity to welcome you all back, and thank you for all of you who are joining us again tonight for our third week MUGIS 2021 Virtual Symposium. So for my presentation tonight, I'll be discuss on the topic of leak after esophagogastrectomy. What should we do? So if you know, gastric cancer is not only one of the most common malignancy, but also one of the leading cause of the cancer-related mortality worldwide. Gastrectomy with lymphadenectomy is a standard treatment for gastric cancer. Total or proximal gastrectomy followed by esophagojejunal anastomosis is a standard treatment for gastric cancer involving the proximal stomach and for the adenocarcinoma of the esophagogastric junction. So despite the advances in the surgical technique and perioperative management, anastomotic leak in upper gastrointestinal surgery remain a serious and potentially fatal complication. So gastrointestinal surgery is associated with a strong inflammatory response both during and after surgery. So patients usually require an adequate cardiopulmonary reserve to be able to meet the metabolic demands of the surgery. So the respiratory complications are the most common cause of morbidity and mortality following upper gastrointestinal surgery. Nevertheless, the anastomotic leakage after upper gastrointestinal surgery is associated with major morbidity and mortality. mortality. As I mentioned earlier, anastomotic leakage after esophagectomy and gastrectomy is a feared and a potentially life-threatening complication. So recent years, we can see a major paradigm shift in the management of leakage after upper gastrointestinal surgery, from surgical management towards non-operative and endoscopic treatment as the first line of approach. So looking at the incidence of anastomotic leak in total gastrectomy, the incidence has been reported ranges between 0 and 17%. So the increased leakage-related mortality was described as 19 to 64%. So the incidence range between 0 to 40% in esophagectomy, and is higher reported in cervical anastomosis rather than intrathoracic anastomosis. So a large number of studies postulated an elevated leakage-related mortality between 18.2 and 35%, with a threefold higher risk of mortality after leakage. So higher mortality in patient reported in patient requiring surgical intervention. So if we know anastomotic leak has a negative impact on other post-operative outcome by potentially increasing pulmonary complication, increased median length of hospital stay, delay in initiation of the oral feeding, and also long-term risk of anastomotic stricture, and probably they require further resurgery at a later time. So what are the risk factors of patient developing anastomotic leak? The identification of the risk factor of anastomotic leaks actually help us to decrease potentially incidence. So we can see here, we can further subdivide the risk factor into patient factors, tumor characteristic, intraoperative, or the surgeon factors. Among the risk factor, among patients, which is commonly being sarcopenia, malnutrition, presence of cardiopulmonary insufficiency, obesity, and also smoking. And we can see also in tumor characteristics, proximal tumor usually associated with higher risk of anastomotic leak, advanced stage of the tumor, and intraoperatively, such as insufficient blood supply, or too much of tension on the anastomosis also put on the risk of anastomotic leak. Surgeon factor has been reported in the study that inexperienced surgeon which perform less than 30 cases significantly put a higher risk of anastomotic leak, and also technical error during performing the anastomosis, also risk of the anastomotic leak, and the prolonged operating time was an independent risk factor for anastomotic leak. So while several researchers has established classification based on the degree of the esophageal anastomotic leak, there is currently no universally accepted classification. I've just shared here, Scotchard et al. In 2015 actually classified the anastomotic leak into 4 classes. First class, class 1 is actually described as a radiological leak only, which require further no intervention. Class 2 described as leak less than 10% of circumference requiring percutaneous drainage. Class 3 described as disruption of the anastomosis, which is about 10 to 50% of the circumference, with a pre-anastomotic abscess, which require endoscopic intervention or surgery. Class 4 described as necrosis with anastomotic separation more than 50% of the circumference, with usually requiring emergency surgery. Professor Clavian et al. Introduced an innovative system for grading complication based on the type of therapy required, called the Clavian-Dindo classification. I think most of us here were rather familiar with this classification. This classification uses objective criteria, providing the same result regardless of the subjectivity of the observer. So the Clavian-Dindo classification is used worldwide and considered to be the most reliable classification system for complication, including anastomotic leak after gastrectomy. In 2015, the Esophagogastrectomy Complication Consensus Group ECCG addressed the issue of the incoherent reporting on the post-operative complications such as leakage and conduit necrosis. So the table that I share here provide an overview about the new classification as proposed by the expert panel. So you can see here that they further divided the anastomotic leak into three different types. Type 1 described as the local defect requiring no change in therapy or treated medically or with dietary modification. Type 2 localized defect requiring interventional but not surgical therapy. Type 3 localized defect requiring surgical therapy. But for the discussion tonight, I will mainly concentrate on the principal management of the anastomotic leaks following gastrectomy. So how do we make a diagnosis? Successful management of anastomotic leak depend on the early detection and the prompt treatment. The initial clinical signs are often very non-specific, such as fever, elevation of the total white cell count, or C-reactive protein and non-specific abdominal pain. Presence of digestive fluid in the surgical drain is an unequivocal evidence of anastomotic leak. So upper GI contrast swallow used to be performed routinely in most of the center before resuming oral intake after upper GI surgery, because it's rather easy and inexpensive. Personally, in our practice, we no longer routinely perform contrast study after gastrectomy unless there is a clinical suspicion of leak. Then it will be performed in selected patient. So the diagnostic sensitivity of anastomotic leak is rather low, and the contrast swallow can give a false negative result in some patients. So you can see the early and aggressive treatment is very vital in order to prevent the patient deterioration. So endoscopy also can be used to diagnose anastomotic leak in patients with clinical evidence of leakage with nearly 100% sensitivity and specificity. So it's also allow intervention at the same setting by, for example, placement of stent or nasojejunal feeding tube distal to the anastomotic dehiscence. So despite the concern that endoscopy may worsen a pre-existing leaks, it is well tolerated and safe when performed by the experienced endoscopists and surgeons. So next is we're gonna do a CT scan. The presence of pre-anastomotic air and fluid on CT evaluation usually strongly suggests an anastomotic leak. So in most patients, with anastomotic leaks, they usually experience clinical signs such as fever, and because contrast swallow tests usually have low diagnostic sensitivity for leakage. So routine post-operative contrast swallow is usually not recommended as early detection. And although the endoscopy is highly sensitive and specific, it is not routinely recommended because of the cost and the effort. So we suggested that if the anastomotic leak is suspected based on the clinical signs, CT scan should be performed first and then followed by the contrast swallow and or endoscopy if needed. So CT scan not only can detect peri-anastomotic collection, it also can detect intra-abdominal collection or other abnormalities such as ileus. And also at the same time, it can assess the extent of the abscess and the accessibility to a percutaneous drainage. So management, depending on the factor that is that can influence the management of patient with anastomotic leak, such as location of the anastomosis, time point of the diagnosis of the leakage, extent of the anastomotic disruption, and perfusion ischemia or necrosis of the conduit, involvement of the surrounding organ, whether or not the leakage is contained, clinical symptoms, either mild or severe sepsis, and whether the success of the initiated treatment, which is mean that if we try non-surgical treatment, whether it's successful or not, that will further influence our next step in managing this type of patient. So what is the principle of management? Based on the recent improvement and development in conservative and endoscopic treatment option, this patient can mostly manage without a surgical re-intervention, and conservative, non-surgical or endoscopic approach are nowadays considered the first choice of treatment in selected patient. So most patients usually present only with minor which contain leakage and relatively asymptomatic. Majority are minor and can be managed by conservative management such as nasogastric suction, local drainage, antibiotic and jejunal feeding. In major thoracic leak, early identification is very important because they may present as atrial fibrillation. They require volume resuscitation, antibiotic, and pleural drainage. In case of worsening sepsis, patient will require early surgical intervention. So signs of leakage strongly influence the clinical symptom and appropriate treatment. For non-operative management, at the very least, fasting and IV antibiotic are necessary. Nutritional support is preferably administered via the enteral route, downstream of the leakage site, with a feeding jejunostomy or a nasojejunal feeding tube that can be placed radiologically or endoscopically. If enteral route is not an option, total parenteral nutrition can be considered in this type of patient. And some people might want to start a somatostatin analog to reduce the enteric secretion. So CT scan should be performed before deciding for non-operative management. If there is only small volume of fluid surrounding the anastomosis, surveillance without percutaneous drainage is possible. If a significant fluid collection is detected, radiologically guided percutaneous drainage should be considered. The other option via endoscopic therapies. The suggested criteria for endoscopic treatment of anastomotic leakage are small leak, rather more than 2 centimeters and less than 70% of the circumference. And the use of stent in the treatment of post-operative anastomotic leak has been reported with variable success. The issue with the stent placement are relatively higher rate of stent migration and the potential tissue in or overgrowth. So other than stent, non-stent endoscopic methods such as endoclip are designed also for endoscopic treatment of anastomotic leak with a high clinical successful rate in the rather small anastomotic leak. And over the scope clip system as an innovation to the non-stent endoscopic therapy demonstrated to be effective to close a larger defect of the gastrointestinal wall resulting from the gastric fistula or anastomotic leak with a high successful rate. Biological sealant has been reported in some rather small case series, but it shows a rather low successful rate. So in addition, the endoluminal vacuum therapy is a promising new and effective method in treatment of upper gastrointestinal leak and perforation. Basically, the concept is similar like VAC for our wound therapy. And then endoscopic vacuum therapy provide a continuous negative pressure that will decrease the bacterial contamination, secretion, and local edema. Thus, it actually promotes perfusion over the surrounding tissue and the formation of granulation tissue. So what is the indication of surgical treatment? Despite the fact that majority of leakage can be managed conservatively or endoscopically, there are few indications for surgical re-intervention, particularly in relation to patient condition and the severity or worsening of the symptom in clinical signs. You can see that one of the among the indications for surgical intervention, such as sepsis with one or multi-organ failure, signs of diffuse peritonitis, or the evidence of inefficient drainage through radiological or endoscopic drainage, or jejunal limb and necrosis. So the principle of surgical treatment is exploration of the anastomotic site to fully assess the extent of the leakage and potentially and the potential ischemic necrosis of the surrounding tissue, so that it can guide us for further treatment intervention of the patient. Second, decontamination of the surgical site by means of the thorough wash-up decortication of the thoracic cavity if it involves into the thoracic cavity from necrotic and fibrotic tissue, thorough washout of the abdomen, abscess, debridement, and so forth are crucial for the sepsis control. And subsequently, adequate internal external drainage of the leakage has to be established by using large drain and nasogastric tube. So what are the surgical options when the patient requires surgical intervention? First, we either could be directly repair the anastomosis if the anastomosis leak is small, or sometime in early stage in technical error, we might need to redo the anastomosis, or in severe cases where the patient is in sepsis, we might need to take down the anastomosis and then do a feeding jejunostomy and closure of the esophagus with the endoluminal drainage. Or in the cases where extended gastrectomy was performed, where our anastomosis might be in the thorax, cervical esophagostomy might be indicated. So for post-gastrectomy leak, surgical treatment is indicated in case of failure of non-surgical intervention. So let's say our failure of a first initiated treatment. So step-up approach is when our radiological intervention or endoscopic management is failed. So that also one of the indication for surgical treatment. Early leakage, which is occur within 72 hours after initial surgery, usually interpreted as a technical error. So usually the redo anastomosis need to be done, or sometime in the small leakage, directly close the leakage can be done, but is actually associated with a higher recurrence of leakage. So the other factor is extent of the anastomotic disruption and condition of the tissue. Defect larger than 2 centimeters or 1/3 of the circumference are usually not suitable for endoscopic treatment. Anastomosis usually has to be taken down, sometimes followed by the direct refashioning. Alternatively, diversion need to be taken into consideration with restoration of the intestinal continuity at a later date. So how's about the outcome? Surgical reintervention for leakage after gastrectomy carries a high risk of morbidity and mortality. And mortality after surgical reintervention is higher compared to conservative or endoscopic approach. So usually it's affected by interval from the diagnosis to the intervention, size of the leakage. Like I mentioned in the beginning, the resuturing or refashioning of the anastomosis often lead to poor result. Risk of recurrent rate is rather high. And surgical reintervention carries a high risk of morbidity and mortality. And surgical revision usually associated with inferior long-term survival. So before I finish, I just share our experience for the past 5 years. We had 139 cases of gastrectomy over the 5 years. Among these, we had 4 cases of anastomotic leaks, about 2.9%. And one of it, we had a non-operative management because it was just a radiological leak. Successfully managed with the conservative management. And one patient required re-laparotomy and repair, just a refashioning of the anastomosis. And two other cases, we had a delay referral, which anastomotic leak was rather detected late. And then an intervention was also performed delay, which is about after 1 week of surgery. So in these first 2 cases, both patients will recover rather quickly. And the other 2 patients, one had a stricture, anastomotic stricture eventually, and will have to be dealt with a dilatation. And one patient did not really recover, had a recurrent bout of sepsis from the collection and line sepsis, and he succumbed to the illness following that. So in summary, leakage from the esophagogastrectomy is a serious complication associated with the increased mortality rate and prolonged hospital stay. No consensus has been reached at the best method of treatment, and the rate of the failure remain significant. Choice of treatment have to be tailored and individualized according to patient clinical symptom and signs. So mortality is still high in patients with severe peritonitis despite aggressive surgery. Conservative non-operative management is helpful in clinically stable patients with small leakage. So if we can mention endoscopic treatment with clip and stent placement may allow complete recovery in many cases. So while all these options fail, major surgical options are available. So the most important thing is actually early recognition and the prompt treatment when the patient is suspected of anastomotic leak. In the center, that if you don't have any a specialty in managing the anastomotic leak, a re-referral is recommended. Okay, this is my reference for my presentation. With that, I finish. I thank you. I will take the question later at the end of.
Thank you, Ms. Hashima. There was a very comprehensive talk. We next move on to the next topic, which will be delivered by Mr. Hans Mahindran. Mr. Hans Mahindran will be talking on upper GI training pathway and services in Malaysia. He is a consultant upper GI surgeon at Hospital Sultanah Aminah, Johor Bahru, a high-volume center receiving upper GI cases from the southern sector of Peninsular Malaysia. He serves as the head of surgical services for upper GI surgery and is the chairman of the Malaysian Upper GI Surgical Training Committee. He's also currently the president of MUGIS, Malaysian Upper GI Gastrointestinal Surgery Society. So, Mr. Hans, over to you.
Thank you, Mr. Chairman, for the kind introduction. My name is Hans, and I'll be talking to you tonight on upper GI surgical services within the Ministry of Health, Malaysia. So if I can get my slides to start. So I think it's important to give credit where it's due. It all actually started with this gentleman, Professor Dato' Kandasamy, who actually mooted the idea of formal training for upper GI surgical services and took it upon himself to actually train one surgeon in Hospital Seremban between 2004 and 2006. The gentleman he trained was actually none other than Mr. Ramesh Gurunathan, who was the candidate, completed his training in Portsmouth 2006, and upon returning from the UK was immediately appointed the head of upper GI surgical services under the MOH. The first upper GI surgical unit was actually established in Hospital Seremban, which has now been renamed to Hospital Tunku Jaafar. So this is from our inaugural upper GI surgical conference in May 2008. You'll see Mr. Ahmad Sudirman, who was with us last week, consultant upper GI surgeon. This is the Professor Simon Law, one of the renowned upper GI surgeons in the region. The great Takeshi Sano. This is, of course, Mr. Ramesh, Mr. Andrew Gunn, who oversaw upper GI surgical services delivery in Johor for the longest time. Professor Jimmy So in Singapore. This is also Professor Simon Wong from Hong Kong. This is Dato' Kanda. This is Professor Jasmine Ali Yaakob, who was the laparoscopic surgeon in University of Kebangsaan, Malaysia. We have him to thank for a lot of things. And this is Mr. Ahmad Marzuki, who went on to become the head of upper GI surgical services later on. And this is Mr. Lokman, a laparoscopic surgeon. This was the previous head of surgical Seremban. This suspicious individual in the corner, we will just probably ignore for now. So what was it like back then? We actually started off with Hospital Seremban. Soon after, opened Hospital Sungai Buloh in 2008, 2009, and Hospital Sultanah Nur Zahira in Kuala Terengganu. We also had Sultanah Bahia under Mr. Wan Najmi. We had Hospital Pulau Pinang under Mr. Lim Shangi. But sad to say, over time, we had attrition. We lost Sultanah Zahira, we lost Sultanah Bahia, we also lost Pulau Pinang as a center. And at one point in time, it just ended up with just Hospital Sungai Buloh being the only center available. So those were the good old days. Now, where are we? Now in 2020, 2021, I'm proud to say that we actually have 5 centers under MOH. The northern region is covered by Hospital Pulau Pinang under Mr. Kelvin. The central region is covered by Institute Cancer Negara, which has the biggest team, 2 consultants, Mr. Muhammad Shukri and Ms. T. And Zone Selatan, which is myself. We have Mr. Ui in Queen Elizabeth, and we have Ms. Hashima in Hospital Umum Sarawak. Now, with regards to the 3rd year, 4th year, and such, this is the number of years post-training that we're looking at. And it's important to note this because everyone keeps asking me, what is the time frame before your surgeons leave? And we actually looked at it, and the average duration of service before most of our consultants go to private practice is about 4.5 years to be exact. So knowing this little tidbit of information, it's important to plan where are you likely to lose your surgeons. So we really need to ensure that none of the centers actually close down. And 2022, we'll be assigning a new surgeon to Hospital Pulau Pinang. In 2024, there'll be a surgeon to IKN and also JB. And in 2025, we will get a new surgeon to Queen Elizabeth and also Sarawak, Kuching. So this is how we intend to progress, but you'll notice with small numbers, expansion becomes very, very difficult because truth be told, my only priority is to ensure no single center ceases operations. So 3 to 4 candidates per year, it's just enough to maintain service. So, and why should services be regional or centralized? Because I would like to use HSA as an example. HSA, which is a Upper GI Center under MOH, you'll notice it's very important to have multidisciplinary meetings. Here, it's actually the ERAS task group meeting between anesthesia, general surgery, and all the subdivisions. We actually have a very strong nutritional support therapy team, which has been doing great work. We actually have combined clinics with oncologists on top of monthly MDT. So there are 2 periods of time that we actually discuss cases in depth to decide what's the next course of management. And we have combined radiology conferences, which results in better patient selection, better outcomes. And really, this is actually a post-neoadjuvant case. So, and that translates into very good patient recovery and good oncologic outcomes. But of course, we cannot neglect ICU. So this is what you're looking for. For a successful outfit to do well, you need to have a team. It's not 1 surgeon, it's not 2 surgeons, it's actually a team. Everyone needs to work together before you can achieve it. And this is the issue. You need to have collaboration between NST and ERAS. You need to have even line care and central catheter teams. And that's one of the major mobilities that we have encountered. You need to have combined oncology clinics, MDTs. You need to have very good ICU support. You need to have trained, experienced nursing staff. I cannot emphasize how important it is. You cannot have junior staff or rotating staff just taking care of your patients. You need to have a dedicated GI pathologist, because if your pathologist is reporting 20 notes, is more than adequate. That's not good for you, because that's one of the reasons why if you look at PT2N0, M0, or even PT3N0, M0, you notice that the survival rates are very, very poor. It's because we're underestimating the node status. Harvesting 20 nodes by palpation is not the way to go. And you need good interventional radiology teams. All this together needs to come together so that you have good outcomes, and you need to benchmark yourself with audits. Audits are important. So surgical mortality, failure to rescue. We've actually come to realize that if you look at high volume centers who do similarly complex cases, why do some centers do better, some centers do poorer with regards to mortality? It's actually because of failure to recognize and intervene. And this was actually clearly elucidated by Kaferi in his paper. He actually looked at it for about 84,000 patients that were recruited in inpatient general vascular services. The complication rates among all these established centers were relatively similar. So when you look at the very low, medium, and very high mortality, major complication rates also are quite similar. So it's not that we don't have complications. We all will have complications, but what really makes a difference is the ability to actually intervene when the complication occurs. Because if you don't have enough resources and you don't have proper pathways, that's when you start having mortality. So in regards to upper GI surgical training, I'm proud to report that The Malaysian Upper GI Surgical Training Committee has been established in 2020, that was last year. And we actually have 7 core members. With 7 core members, we actually have myself, Mr. Shukri, and Ms. Hashima, who are the team leads of our respective institutions. Binding us all together is actually Mr. Ramesh representing the society. We have the 2 professors, Prof. Lau and Prof. Nick, who represent the public universities. And we have Mr. Lim Shang-yi, who actually represents the College of Surgeons. So with this, we actually have 3 previous heads of national service and myself. And what we do is we actually oversee the delivery of the training program. Trainee selection, we monitor trainee progress. We also look at the selection of trainers and training centers, and we actually do regular review of the curriculum. This is important. So upper GI training is actually a 3-year program, whereby ideally 2 years locally and 1 year overseas. What we will do is we actually have the candidates actually rotate between centers such as HSA, IKN, and maybe UKM. And we will try to let them go overseas 9 months, 12 months, depending on scholarship, on whether they can get paid posts. They must know what they're trying to achieve overseas. It's not just a matter of looking at systems, but they're trying to usually bring back a particular skill set. So that's why the committee needs to look at it case by case to a proper center and what exactly is we're trying to achieve. And we're actually quite flexible. It can actually occur anytime in the second half of year 2 or anywhere in year 3. So we are trying to aim for hands-on training. The trainee, once they join the program, is directly involved in patient care. They actually have to do the procedures, they have to do the planning, they actually have to review everything from start to end. And that's in order to achieve the range of competencies, which is technical and clinical, which is what we are looking for. And it's not a matter of you just being able to operate. You actually need to be able to achieve the milestones, good dissection, meticulous dissection, good outcomes, good patient care. And, the trainee actually undergoes a continuous workplace-based assessment, whereby they will run the scope list, they will perform intervention, we log the scopes, we take the images, we review it, and we've actually got a pretty nice archive of images that we're actually using for training actually now, for other educational activities. And we do a lot of directly observed procedural skills whenever possible. So intervention, surgery. When it comes to surgery, what we do is we actually give them tasks to do small parts, little by little, until they're able to complete the entire procedure all by themselves. And once they can do that, then you notice that the poor trainer just sits in a corner and just kind of observes most of the time. So you have to take a back seat. And the training does not end in theater. The joy of laparoscopic surgery is now that we're recording, and the recordings are very important because you need to review all the recordings in a controlled environment, and we will review every week. Procedures that were done, reviews, either model cases or cases that we feel that there's a learning point, we'll actually discuss in a review so that the candidate can identify where they actually deviated from the anatomy or where they may have made an erroneous movement. And it is this kind of training that we're trying to achieve so that they have good muscle memory at the end. And discussion, it all ends with discussion. You need to have the training hours whereby they can actually sit down and discuss what they saw, what they learned, what are the problems they encountered, and how to do it better. And this is how your trainees progress. So this is what is expected from each training center. They have to do their own operative video reviews, preoperative discussions. They need to have their own radiology and pathology conferences and on MDT meetings. But that alone is not enough, because in the past, we actually noticed that certain centers tended to have this training and silo mentality. So that you actually would have institutional variation. To avoid that, actually now we, the National Committee, have actually organized weekly scheduled case discussions, journal clubs, whereby we let all the candidates participate. Thanks to Zoom, actually engaging all the trainees from all the centers, and all the trainers actually come for 2 hours every Monday night. And you'll realize immediately that this is a lot of commitment. So the trainees are engaged in discussion. They can actually, this is if they're going to make mistakes, they better make it here. What you want to do, what you're looking for, where there are needs, dilemmas of management. And between the 6 centers, there's definitely no shortage of material to discuss. So, but of course, these sessions, many of you will be wondering whether you could probably join them. Sad to say they're closed sessions because we can't really black out a lot of the images, and that's patient confidentiality will be affected. For more public discussions, we actually will organize an annual webinar series, more operative workshops, and also endoscopic workshops. So I encourage you to look at the MUGIS website later on, because a lot of these activities will be starting next year. So with regards to trainee assessment, how do you know if trainees are doing well? It's a lot of continuous assessment. That's the way to go about it. And it involves, sadly, logbooks and audits. As part of the continuous assessment, trainees are expected to maintain a meticulous logbook and, of course, participate in the Malaysian upper GI cancer audit. So they are expected to do a reflective logbook, which is important, so that you can see the progression of the candidate. And hopefully with this kind of data that we're collecting, we should be able to present current trends with regards to upper GI cancers and hopefully update this annually. What we're trying to actually achieve is something similar to what August is doing, which is really impressive. So time to treatment, patient navigation systems, curative surgery outcomes, 30-day, 90-day mortality, which is important in identifying institutional issues or failures. It's usually systemic, not really surgeon most of the time. Completion of chemotherapy, rates of toxicity, and of course, palliative care outcomes. All this is important because if you're going to have a subspecialty service, you need to be accountable to someone, and we are accountable to Ministry of Health. How are we doing? Where are deficiencies? We need to identify this, and this is where data is actually important. So the problem of logbooks, many people have actually told me that no, logbooks are not the best way to look at it. I agree, logbooks are not an effective assessment for training competency, but they do have the roles, especially if you look from perspective of case mix, level exposure. You're trying to see what the candidate has been seeing, but it's a very blunt tool to measure technical expertise, so we know that. But it does help identify deficiencies whereby we can initiate remedial measures if the candidate is lagging behind. Of course, you could say that the pandemic has definitely affected us. That is undeniable. Looking at my own center, this is a little bit that I did. The total number of cases has definitely dropped throughout the pandemic, benign cases being the most affected, but cancer cases, well, it's kind of plateaued off. So the cancer cases will need intervention. What really affected us was the limitation of ICU beds and, of course, disruption of the referral pathways. So when you look at logbooks, these are our candidates. Actually pit the candidates against their own cohort. So you have the third-year candidates, you have the second-year candidates, and you have the first-year candidates. So you actually put them against their own cohort. So any candidate performs below than the rest, and this is when you decide, oh, we probably need to either do we need to reassign them, maybe give them a short attachment in a higher volume center for a period of time until their own systems come back online, or do you want to organize perhaps a workshop that we can just bring in the numbers and just boost their numbers like that? So what do you expect to see? Or candidates who completed year 2, 2 years of training for 59 gastrectomies, 17 GIS, they're separate. We don't lump them up together. 47 esophagectomies, 2 excisions. This is one of our current third-year candidate. Our second-year candidate completed year 1, 38 gastrectomies, 4 GIS resections, 19 esophagectomies. And what's interesting is, I'd like to highlight my first-year candidate is actually doing esophagectomies, of course with supervision, but they are doing. And this is important because we drill them to perform part by part until they can complete the procedure, and we're not aiming for competency actually, we're aiming for mastery. So why so much effort? Well, we must go back to what was the program objective. We want to produce subspecialty surgeons who are experts in the latest treatment strategies in managing both benign and malignant upper GI pathology. They need to have a high level of technical competence performing the procedures using latest techniques, laparoscopic and endoscopic techniques. They must be committed to the advancement of the service in MOH while training, research, and planning and policy actually. And they will integrate with surgical teams that they are attached to. And they will, of course, always demonstrate the highest level of professionalism towards their colleagues, staff, and patients. We are generally trying to train a senior surgical consultant because that's what they are once they complete training, because they will have to manage cases by themselves and they will have to develop the service around them, engaging oncology, pathology, radiology, NST, intensive care, and palliative care. And that's when you know that you've got a successful candidate. We generally, this is the last slide, so we are facing the same challenges as before with small intakes and such. Maintaining services is very important, and we need to ensure that there's high standards of practice while we do more to train and develop pathways and also embrace new technologies. I'm proud to say that ICANN is now doing a lot of ICG work. We're very impressed. And I do not know if we will be able to go robotic by the end of this decade, but it's something food for thought. So with that, I think I'd like to end here. I'd like to just give a small quote there, multiple permutations of this. We must know where we came from if we actually want to know where we're going. So with that, thank you. Good night.
Thank you very much, Hans. It's quite very comprehensive. Thank you very much. So let's move on. The next topic that we are going to hear is about the Upper GI Fellowship abroad versus East versus West. I believe the first part is Dr. Kelvin Woon is going to talk about the East. Let me just introduce Kelvin for briefly. He's at this moment based in the hospital, Penang Hospital, as a head of Upper GI Surgical Unit under the Ministry of Health of Malaysia. That's where he received all the referral from the northern sector of the Peninsula of Malaysia. His main interests include minimally invasive esophagectomy, bariatric surgery, and clinical nutrition. He's actually also a visiting lecturer for RCSI, Royal College of Surgeons of Ireland, and UOCD Malaysia campus. He's very active in our a new fraternity, what we call the Upper GI Gastrointestinal Surgeons, TAGS. He's Asian coordinator. He's very active both in local and international Upper GI platform as well as in the surgical training. So I pass the platform to you, Kevin.
Thank you, Mr. Yap, for the kind introduction. So I'm tasked today to share with you on something that is light and easy, right? There's no level 1 evidence here, it's probably just level 5 evidence based on my personal experience during my 1 year of Upper GI Fellowship abroad. So I spent 1 year in Shanghai, Taiwan, and a very short stint in Shizuoka Cancer Center, Japan. So we're just going to go through 3 areas. Number 1, of course, the points to ponder when we decide for our fellowship abroad. And I guess everyone knows the rules, okay? If you fail to plan, means you are planning to fail. So hopefully I can shine some light on your decision on how to make early planning for your overseas fellowship. And lastly, just to share with you my journey to the East. Now, these are the common questions that pop up whenever we come to the junction that to decide, okay, where should we further our training? So which center to go, which mentor to follow. Okay, if you need any connections or referrals or any advice, feel free to come to us. I think the fraternity is all ready to help to get you a good center to go to. And more importantly, you should consider that the center that you plan to go, whether the disease pattern is similar and whether the training is recognized in Malaysia. And most importantly, whether whatever that you're going to learn abroad is applicable when you come back. Okay. So a few points to ponder, I divide them into 5 areas. Number 1, you must clearly know what is your objective of going abroad, because you're going to spend 1 year of your career. You may have to spend your own money as well to invest in your training. So you're going to be very clear of what you're going to achieve, whether you're going to go for a high volume center, you want to get something like more hands-on in terms of maybe esophagectomy or gastrectomies, or you're happy with a research-based position. Okay, whether you are happy with just going there to see, observe without touching the patients, and whether you want a paid job or not. Okay, generally nowadays it's relatively easier to get a paid job, especially in UK due to the relaxation in the regulation as well as the need of manpower. But let's say you get a paid job also means that you are obliged to the working hours. You have to go by the rota, you have to go on call, and maybe you probably have to cover more of general surgical cases as well as do some groundwork and paperwork based on the position that you got. Okay. Second thing, of course, money matters. So you have to think about your expenses in terms of accommodation, the food, daily expenses, whether you need to pay fellowship fee to the respective center. And also one thing about going to the West, of course, is the currency conversion rate can be quite high sometimes. And also you have to pay for your healthcare insurance as well as indemnity if you want to work there. And what about the cost to travel home or cost to travel around during your free time? And trust me, if let's say you're going to pay for some of them, just invest it in yourself. It's going to be really a priceless experience. Thirdly will be the social cultural difference, whether the language, the lifestyle, and the food there suit you. If all this doesn't suit you, then no point you go there for a year to suffer. Okay. And the fourth issue, of course, is the distance and the time difference to Malaysia. If let's say you are someone that's going to call home every day or every week, so the time difference may be a difficult point for you. And what about if let's say you want to travel back home in between? What about the distance and timing to travel back? And lastly, if you have a very committed family man, you're going to bring your family along, you have to think about their social welfare, their healthcare, as well as the education for your kids as well. Okay, so how should we plan early? So I would suggest that number 1, you should decide roughly which are the shortlisted centers that you want to go to, look up for the professor or the chief in charge, try to send them an email, or you meet them in conference or webinar nowadays, leave the contacts, express your intention of going over and stay in touch, okay? And I strongly encourage every one of you to pay the center a short visit, probably a 1 week stint before you commit yourself for 1 year. You get to know the people there, know the working system, and know the environment, whether it really suits you for a year, and whether you really will gain something out of the 1 year or not. For example, some of the international congress, the KINCA Gastric Cancer Congress by Korea, they have this 1 week complimentary Center of Excellence visit program that usually end with a animal lab hands-on workshop. So it is free of charge. You just have to apply whenever you apply to participate in the conference with some presentation. And another thing that you have to sort out early is, of course, all the necessary paperwork, approval by KKM or by the universities, and also your working visa, right? So for me, this was me in 2017. I went to Beijing to attend the IGCC Congress, and so happened that they have this hospital visit program. So you can see here, this was part of the Malaysian team that were there back then, and this was my team from Penang. We always go without empty-handed. We either go with poster presentation, if not an oral presentation. And mind you that actually there is travel grant awarded if, let's say, your presentation is being accepted, and awarded a travel grant means it can go up to as high as 500 USD, then you save your traveling expenses. So I then went on to 1 week visit to Zhongshan Hospital in Shanghai. That was my first encounter with this center. So I was there with 2 Italian surgeons, and this is Professor Sun, the chief of gastric cancer unit. So we were shown around the ward round, the OTs, the surgery, and also we participated in the multidisciplinary team tumor board meeting. So I was really impressed by this center because this is one of the top hospitals in China, and the unit does 1,500 gastrectomy a year and 450 esophagectomy a year. That numbers are really amazing, and that really impressed me. Of course, the outcomes are also very impressive. So when I was thinking about the overseas training, so these were my 2 main areas that I want to strengthen. Number 1 is on upper GI cancers, especially MIE and a proper lymph node dissection. For obesity and bariatric surgery, I want to have more exposure to the latest innovation and, of course, the latest procedure that is being performed nowadays. So thereon, we know that esophageal cancer has the highest incidence in East Asia, especially in China, right? That was one of the main factors that I hated East. So, and for me, esophagectomy is a highly complex procedure because looking at the esophagus, it travels through 3 compartments, the neck, the thorax, and the abdomen, and it is located adjacent to most of the very, very important structures in the thorax. And to make things more interesting, the 2 recurrent laryngeal nerves also run along the esophagus, and we need to clear the lymph nodes away from these nerves, because for upper and middle thoracic esophageal cancer, the risk of metastasis is as high as 20% to this group of lymph nodes, right? So I was also impressed by the outcome of MIE versus open esophagectomy. Certainly, there is a great improvement in terms of perioperative as well as short-term survival. And a good oncological surgery is not complete without a proper lymph node dissection. So this is something that I wanted to learn more and explore more in my overseas training. So just to share with you my experience, journey to the East. So I was there in 2019, 2 years after my first visit to this hospital. This is a main tertiary hospital in Shanghai, 2,000 bedded, and one of the top with 80 years of history. So I was mainly in 2 departments. One, of course, is the gastric cancer center under Professor Sun, and this is my direct mentor, Professor Shen Zhenping. So I then also spent a few months in the thoracic surgery unit headed by Professor Tan Lijie, because in China, esophagectomy goes under the thoracic surgeon, just as similar to US, right? So things that I've learned, of course, selective ERAS has been practiced worldwide. This is something that is similar that they are practicing in China. And other things that I find useful is, for example, we feed the patient olive oil the night before just to enhance the visibility of thoracic duct to reduce the chance of injury. And the thing that I find it most useful is doing an MIE without single lung ventilation. Okay, so our patients are usually intubated with the normal single lumen ETT. We keep both lungs ventilated. This certainly helps to reduce pulmonary complication post-op, and it makes dissection of the paratrachea and the left recurrent laryngeal nerve lymph nodes much easier, because if we put this tube in, it's going to be too stiff for us to retract the trachea. So this is how the OT looks like in Zhongshan Hospital. So they have about 40 ORs that do about minimum of 200 elective OT per day. And this is how we position the patient in a left lateral semi-prone position for the thoracic face. French position is a standard approach for the abdomen and the neck, and this is a usual specimen. In one day, we can do as many as 4 MIE in one OT, because over there 1 MIE only take about 3 hours. So we also do laparoscopic gastrectomy, but of course the volume is not as high, probably only 20% out of the 1,500 cases, because majority of the patients in China tend to present late. And again, open gastrectomy is faster to cater for the high volume and high turnover. So another thing that fascinates me is the patient control epidural analgesia. All right, we only have PCA morphine here, but this one is a patient control epidural analgesia, and patient is made to walk the day after surgery. Usually they have a helper here in addition to the family member to help ambulate the patient, and this certainly improves patients' outcomes. So just to let the data do the talking, so this is Zhongshan Hospital Thoracic Unit. They did about 900 esophagectomy over 2 years. Majority were Machion approach, because majority of the cancer there were squamous cell carcinoma and located either in the upper or middle thoracic esophagus. So MIE contributed to 80% of the esophagectomy in the center, and as I mentioned, they take only about 3 to 3 hours from skin to skin. Okay, so the morbidity is as a concordance to the international landmark about 28%, and the mortality is very low, 1%. And from this simple analysis also, we can know that MIE certainly is the way to go in comparison to open esophagectomy in terms of patient recovery. So besides going to the theater, working hard, we also have many international visitors, because Zhongshan is a world-renowned center. For example, Professor Adam Bass, the primary investigator for the TCGA trial, Professor Rami Pota, the main person in the TNM staging for lung cancer. All right, besides mixing with the foreigners, of course, we get a chance to mix with the local upper GI fellows. So they are from different provinces in China. Although they all speak Mandarin, they also have their own dialect. It's actually quite interesting to know about the background and the healthcare system in each province. And of course, as a foreigner in a foreign land, it's always good to meet up with a fellow Malaysian whenever they come over for a visit. So I was like a pseudo tour for them to bring them around Shanghai. So that concluded my journey in Shanghai in 9 months. I got a chance to attend a JGCA Congress in Shizuoka. So as I said before, I never go empty-handed. I presented 2 oral presentations, and I was awarded a travel grant. And at the Congress also, I got to meet up with Professor Terashima, make arrangement, and I went on to a 1-week hospital visit in the famous Shizuoka Cancer Center. So under Professor Terashima, the chairman of a JCOP team. So as we know that D2 gastrectomy by Japanese is a gold standard, right? They invented the technique. So I really want to see by my own self how they do it. So it was a great opportunity for me to visit them. I got to witness the open technique, laparoscopic technique, and also robotic D2 gastrectomy. I also get to see esophagectomy with a 3-filling dissection by the Japanese. This is Dr. Subosa, the main esophageal surgeon there in Shizuoka Cancer Center. So then I went on to my final 3 months of 2019 to BMIMC in China Medical University Hospital under Professor CK Huang and team. So BMIMC is a very nice and cozy, unique center that occupied the 6th floor of the cancer center in CMUH. So this is how it looks like. The clinic, the gym, the dietitian clinic, the wards, and also the OTs are all in the same floor. And all these chairs and equipments are specially made for obese patients, right? So they have a very clear clinical pathway in terms of pre-op preparation, examination and checkup, and then what are the modalities that they should offer to patient based on patient's BMI, as well as whether the patient is diabetic. So my routine in BMIMC, of course, we have our weekly fellow discussion and also research presentation. We run the clinic together, and also just to tell you that this is not my room, this is patient's room, yeah, right? So this is the gym that we should spend our time after our work, and this is me with my 2 dear mentor, Professor CK Huang and Dr. Matt. Both of them are the consultant surgeon in BMIMC, and it also gives me opportunity to meet up with all the fellows under Professor CK Huang, because we were having a 4th IEF forum back then. So it was again a good opportunity for us to do networking and expand our friendship during overseas fellowship. So again, just to show you why I choose BMIMC, because in Taiwan, there was about 3,000 bariatric surgery per year. BMIMC was the highest volume center and also with the best outcome in Taiwan. So that concluded my journey to the east. So I was back in Penang last year, restarted the upper GI and bariatric service here in Hospital Pulau Pinang. And this is me and my team. We basically just replicate what I learned in Shanghai. So we do MIE in a 3D with a 3D laparoscopy. That's why we are all in 3D glasses. So it really makes a lot of difference in terms of dissection, especially along the nerves and the thoracic duct and the vessels. So this is how we position them. As I mentioned, left lateral semi-prone position with a single lumen ET tube, and we ventilate both the lungs. So these are how we place the pots, and in the French position for the abdominal and the neck face. So due to constraint of time, I'm not going to show you any video, just going to show you some pictures. So for Machion MIE, I routinely make a small 4 cm upper midline laparotomy for me to deliver the specimen, as well as to construct the gastric tube ex vivo. But for Ivor Lewis, it will be totally laparoscopy and thoracoscopy. So this is how the gastric tube looks like, and we pull it up in an orthotopic position to do the anastomosis in the neck. And this is how we do a 3-field limb dissection. First of all, this is the vagus nerve, right? And this is the right recurrent laryngeal nerve here. You can see it clearly going up to the neck. This is the esophagus and trachea. So this part of the lymph nodes needs to be clear, especially in upper and mid-thoracic esophagus cancer. And this is the left recurrent laryngeal nerve here, all right? Trachea being retracted medially, esophagus push up. Thoracic duct is here, nice and juicy. Arc of aorta will be here, left subclavian artery will be here. So again, we have to clear this group of lymph nodes, and it's much easier if you use a single lumen ETT so that the trachea can be easily retracted. For a supraclavicular lymph node dissection, station 101 and 104 is pretty simple. It just can be done with a collar incision, and these are the patient's wound post MIE. And just to share with you my very early experience over the past one and a half years, probably I've done about 15 cases after coming back. So these are the first outcome of the first 10 cases. Majority were adenocarcinoma. All patients require neoadjuvant therapy due to the advanced stage. So I had more of Machion because of the location of the tumor. The lymph node dissection mainly will be depending on the location of the tumor and the distribution of the lymph node metastasis on the pre-op scan. On average, I harvested about 44 lymph nodes during MIE. So mean operative time range from 6 to 8 hours, and usually patient will spend about 7 to 9 days in hospital before I send them home. Pulmonary complication, of course, is the commonest. I mean, all of them recover well. Mainly, they have some left-sided effusion or atelectasis that need aggressive physio and drainage. So I had no mortality up to 90 days. And you can see here, most of the patients had a stage 4 disease. And so far, all of them were doing okay. And like Mr. Hans mentioned in his previous talk, so we are nothing without a good team effort. So in Penang Hospital, I'm blessed with the availability of oncologists, radiologists, even the nuclear medicine departments, and we have very friendly anesthesiologists. I have very good pathologists, all right? For example, in this case, patient have a T1B tumor, but my pathologist still entertain my 15 specimen because I routinely dissect out all the lymph nodes and send separately as a different station, and they can find about 103 lymph nodes, and out of 103 lymph nodes, 67 were positive despite this a T1B tumor. All right. So I also have my very supportive nutritional support team. We do round every Thursday. Of course, we must have a good team effort to rehabilitate the patient post-op. All right. So before I go, just want to express my heartfelt thanks to my local trainers and tutor as well. These are the people that see my development in HPP, including the late Mr. Tan Vijin. And this is Professor Prem, the person which I witnessed how to deal with esophageal perforation during my medical officer time. Dato Kanda has been an inspiration during my undergraduate years. Prof. April and her teams from UMMC, Prof. Nick, Moose, Renu, and the UKMC team, and of course Mr. Suprin and the Hospital Sungai Buloh team. All of them, I felt really thankful for what I've achieved today due to their encouragement and guidance. So in conclusion, ladies and gentlemen, I think subspecialty training is certainly the way forward in this era of modern medicine. You better choose your site, which field you want to go into, right? And fellowship abroad is a crucial step in our career advancement. It can broaden our horizon and also to upgrade our skills and also networking. It is truly a once-in-a-lifetime journey that we should treasure and plan properly. So plan early, and it should be goal-directed. You know what you want to achieve at the end of the 1 year to sharpen your skills and to strengthen the weaknesses. And as I said before, if you fail to plan, we plan to fail. All right, so plan it early, get more networking, and spend a short receipts to decide where you want to go. And lastly, I would just quote Warren Buffett, not so much about the money, but the best investment is still to invest in yourself. I mean, the returns is really priceless. So before I go, just to promote tomorrow's event to you by Professor C.K. Huang and the BMI MC team, it's the 5th IEF Forum. We'll be talking about the current and the future of obesity and bariatric surgery. So include live surgery, GLP-1 agonists, bariatric endoscopy, as well as weight regain management and sleep plus procedure. So with that, I would like to thank you all for your attention. And as a TUX Asia coordinator, I would like to ask all of you to join TUX as well. This is an international global upper GI community, and the membership is free. We have a whole list of academic activities that awaits you. Thank you.
Thank you, Mr. Kelvin, for the comprehensive talk. So Mr. Kelvin has actually shared the journey to the east. Now we would like to introduce Mr. Uy. Mr. Uy Wei Kiat is from Hospital Queen Elizabeth KK Sabah. He is currently the head of the upper GI unit, and he mainly received many referrals in the northern part of the Borneo. His main clinical interest includes esophagogastric cancer surgery and reflux disease. He has published extensively on his interest, and he's active. He's also an active surgical trainer. He has did his training in Erasmus Rotterdam. So I would like to pass the stage to you, Mr. Uy, to share your experience while doing your training in the West. Mr. Uy, please.
Thanks, Mr. Lim. I'm going to share my screen now. If the host can allow me to share the screen. Okay. Hi, good evening, everyone. So Mr. Kelvin have shared with you his journey to the east. I'm going to share with you a very, it's going to be a very light and very informal sharing of my journey to the so-called to the west. But I do not consider myself to be Western trained, rather I'm Malaysian trained. This is my picture, Dato' Kanasani, the one that inspired us all to join the Upper GI fraternity. And I would like to pay tribute to my masters, local masters, Mr. Mahadevan, that trained me while I was doing my training in Seremban Hospital. And of course, none other, Mr. Shukri, who I had my training in Sungai Buloh Hospital. So I do not consider myself Western trained, but rather Malaysian trained surgeon. This is me and him when we traveled to The Hague to attend the ESPN conference. Now, so what is the first step to oversee? This is how it all began. I wrote to Bas, which is my coordinator in Erasmus Rotterdam, Netherlands. When he said okay, so this is where all it starts. So I received my letter of acceptance, invitation to go over, and then the journey begins. Like what Kelvin said, there's a lot of planning to do. You are going. They do not call Europe the fortress Europe for no reason. You have to make sure your visa is properly applied. Your visiting agreement. You have to get your resident permit. So, and then you have to get your housing. And in Rotterdam, they have problem with housing because the Erasmus University is a very huge university. So they are short of actually rooms and house in Rotterdam. So as you can see in this email, I got rejected by 5 or 6 landlord because they were so popular. So you have to plan, and all this starts 1 year before before I even leave to Rotterdam. So now, why Erasmus MC? Why do I choose this place? This is Erasmus. It is the largest. It's the largest of the 8 university hospitals in Netherlands. It has by turnover, by bed strength, they have a combined strength of 1,320 beds. It is a mainly cancer institute. It does not as high volume as China. It does over 80 esophagectomies and 60 gastrectomies per year. And this place, Erasmus, is the birthplace of the cross trial, the famous cross trial, as well as Sano and Tentacle trial. They have about 39 operating theater, about 120 ICU, and they have because it's a new hospital, so they have all the latest equipments there. Now, despite saying all this, actually, the most important thing that I find that it has to suit what I want to learn. Yeah, the place that I go, I want to learn something that I can use when I come back to Sabah. So we went through this. So Netherlands has about 18 million population. Rotterdam covers about 5 million population, which is similar to Sabah. So the size that I'm going to cover will be about the same. So it means that the load that I'm going to see will be the same. And they have distal stomach tumors, esophageal tumor are mostly distal as well. Similar to what I see here. The size of the hospital is almost similar to Queen, where I'm working now. The upper GI team is a small team. They have moderate volume. So I find this very important because yes, China, Japan, Korea, their volume are very high. So the surgeons, of course, they are masters. They are extremely skillful. But I cannot compare myself to somebody who does 1,000 gastrectomy or 1,000 esophagectomy per year. So I can never be like them because they just have the perpetual volume and practice to achieve that kind of mastery. So I admit that I will never be as good as them. So therefore, I need to learn from a place where people do moderate volume, similar to me, but achieve good outcome, achieve good survival. So I'm trying to emulate what this centers does. And Erasmus, they are expert in chemoradiotherapy. And more importantly, they offer a 1-year formal fellowship, which allows me to be in the clinic, to be in the ward rounds, to be in the theater, and I do upper GI calls. Very important because I'll be alone when I come to Sabah. I knew that. So therefore, I really need to know how to handle the complications. So therefore, my goal is I do not just want to be in the theater. I want to be in the casualty and follow the patient all the way to the ward. And if they have any complication after that, I would like to manage them as well. So that was my goal when I was searching for a place to go. So and so happened, Erasmus offers this. It offers this to me. So therefore, we chose this place. Now I promise you that that's the last slide where I'm going to talk so much. The rest are all pictures, so I hope that I don't bore you. So these are the 3 trainers in Netherlands where I go to. Professor Jans Valonskot, he's a professor of surgery there. Then the team is led by Dr. Bas Wijnhoven. He's a director of surgical training in South Holland, as well as the head upper GI unit. He's also a very, very active researcher. He's an editor for British Journal of Surgery as well. And then we have Stuart, a very good friend of mine. He's a consultant upper GI surgeon in Erasmus and also currently the head of surgical resident training program in Erasmus. So we work together, and and for that year, in 2019, there were no local fellow. So the spot for international fellow was filled by me. So I get to basically I was the only fellow following the three of them. So it was quite fortunate. Therefore, I had no one to compete, and I get to do and learn. I get to go to all the clinics and theater as well. Now, so this is the first day. This is how Erasmus looks like. Erasmus is actually built over a museum. So there's actually a museum in the hospital itself. So you will see tourists going to the hospital to enjoy the museum, as well as patients going there. So it's a very nice hospital. So you will receive a tag like this. This tag allows you to access all the, to enter theater everywhere. Everything is accessed through this tag. Oh yeah, I have to see the criteria was that I need to pass my Dutch language proficiency test in order for me to get to be a fellow. So I set for the basics and then up to intermediate. And this is where the every morning at 7:55 sharp, the whole department will gather here for the Passover and by the surgical residents. And then we have many small groups discussion, meetings, MDTs with the oncologists, radiotherapies, weekly. Yeah, we do this weekly. Yep, these two gentlemen on the left is Professor Valonscott, and on the right is Professor Van der Haas. Both of them are the brainchild of the CROSS trial, and yeah, so this is our usual MDT. Yeah, and the hospital is so big that people go around with a scooter. Yeah, this is normal. And this is Stuart, and this is the B&E surgeon. All right. So this is Stuart and Bask. They were looking at all the anesthetist resident. Guess what they're talking? This is the most serious discussion that I've ever seen throughout my 1 year there. And they're discussing why are there more beautiful anesthetist resident compared to surgical resident. I promise you this is what exactly they were discussing. So looks like all surgeons around the world are the same. Okay, this is me in the theater. So I do get to operate initially under supervision, then slowly as they trust me, I get to do some cases. I get to start the cases on my own. The picture below here is a high-tech surgery. Here I operate together with Professor Valonscott. We have robotics as well. I get a chance to perform a little bit from the docking to even performing small parts using the robot. Here is me teaching the residents some, I think, putting a feeding jig or something, if I'm not mistaken. Yep, this robotics. This is where I was the assistant docking the robot. Yep. Now, for more fun stuff, so Dutch people are very relaxed. They are very pragmatic people. The head of department is actually the head of sorry, this is a professor of the GI unit. Sorry, he's a 7 feet tall guy. Yeah, so he brought us out after work to have sort of tea by the seaside. I get to stay in Professor's house. By the way, Professor is a aristocrat, so he owns a castle in the Netherlands. His family runs the Bank of Valonscott in Netherlands. So we get to, yeah, so it's quite fun. Dutch people also have the same problem with us. You look at this toilet here. I think funny quotes that these Dutch people have. I travel around in Dutch using the bicycle. They cycle a lot, so this is my trusty bicycle while I was 1 year in Netherlands. Okay, so we also host quite a lot of visitors to the EMC. So I'm the host here. We host Professor Gong from Wuhan. We host Professor Yang Hangkwang from Korea. We also Professor Carol from Poland. So we do. They have visitors to EMC as well. And then, of course, while you're there, it's a once, like what Kelvin said, it's a once in a lifetime journey. So you get to have fun. This is Mr. Shukri and the Sungai Buloh team came to visit me in the Netherlands. So I get to bring them around. This is my daughter and my wife came to visit me, and we went to Amsterdam. This is the Ajax stadium. I get to go to the Dutch game when they were playing Estonia for the World Cup. So it was fun. We get to go. And Dutch has lots of museums, so you can go to enjoy a lot of museum in Amsterdam. All right, and of course, very important while you're overseas is making networking and friends. So while you're there, so I get to meet people from Leicester, Sheffield, right? Yeah, this is again Carol in Poland. Yeah, and this is Tessa from Greece. So we have friends, so that I think that hopefully in the future we can have more collaboration with them. And I'm going to tell you a story. This is truly amazing. This is Peter. Peter van der Sluis. He's a Dutch guy. So I met him while while we went to a course in Austria. So Erasmus sent me there for I think a hiatal hernia course. So I met Peter there. Peter was a fellow at the time. He was a fellow in Mainz, Germany. He was actually looking for a fellowship job in Netherlands, but he couldn't get one. So when he met me, he was so surprised that I could get a fellowship with Erasmus. So he was so happy. So I introduced him to Stuart, and then lo and behold, in 2020, he's now a fellow in Erasmus now. So what he always said, it took a Malaysian to bring a Dutch home. That's what he said. So yeah. While I was in Erasmus, many opportunities in education. I managed to write a book chapter for a book that cost £53. It's quite interesting, yeah. So we wrote about post-esophagectomy leak, published articles in Gastric Cancer Journal, performed audits for Erasmus surgery, and managed to partake in international multi-center trial. Get to teach master students, surgical residents, Dutch residents, as well as I get to go for classes, hiatal hernia classes. Yeah, they even sent me to other parts of Europe as well. So it was quite interesting, and yeah, and last but not least, I even get to star in the Dutch national TV. So at that time, there was a national, there was filming the show Top Doctors, and they actually caught me, filmed me while I was operating with my boss. So it was quite fun. There was to show up in the Dutch national TV. Yeah. So it shows in their channel 4, so you can see me operating. So yep. And then there was 1 year. So this is the final farewell dinner. So I got a certificate for my fellowship there. And yeah, so that is my journey to the West. Very informal, light sharing with you. But jokes aside, apart from going to the West, I also had a chance to go to similar to Kelvin. I did spend some time in Shanghai as well, through the IGCC conference where we won the travel grant together. That gives me an insight to how the Chinese does the surgery. So I can clearly, I can really see the difference between in terms of surgical skills. But what I really wanted before I left that time was I wanted to go to a place where I can be more comprehensive, where I would like to see everything. Yeah, so that was my goal. So yeah, just a advice to the future. I mean the trainees that are planning, right? So you have to set your goal early. What do you want to do? What do you want to learn? And whether can it be applied to where you are? See, so there's no point if I go to Netherlands and I tell my boss I want to do robotics, you know, and then I come back and I can't do robotics, right? So I think you have to set your goal early, and you need to know what you want. All right, and with that, yeah, thank you so much for listening to my sharing here.
Thank you, Uy. That was an excellent presentation. A very, what would I say, very thought-provoking, and not only Uy but also Kelvin. I must say that having seen both your experiences, I feel like going back to fellowship and starting back all over again. Very, very engaging. I must say this has been a fantastic night. Although we are running short of time, but I think all of us enjoyed it. I must say I really enjoyed it immensely. And but now it's time to start the Q&A. We have a few questions. Perhaps I could start off by asking Hans. Hans, you very, very nicely presented about how we should go about. And I think you essentially captured what Dato was had all the while thought and planned. And the very first time we started this way back a decade ago. Just a small note about the training. We should, in future, if possible, have a training encompassing both the university and Ministry of Health. What are your thoughts on this?
Thank you, Mr. Vijay. It's a rather interesting question. So the training program that I highlighted, although it's supposedly under MOH, actually involves the university. So now there's only one single pathway, because when it comes to NSR, or the National Specialist Registry in Malaysia, if you're going to get NSR upper GI, you probably need our qualification. So that's how we've actually streamlined it. So as we speak, we actually have a university candidate from University Malaya with us, and we also have a university candidate from UITM with us. So they don't show up on the screen because I only highlighted the Ministry of Health candidates, but actually another two more. But
that's
because
very
the
good.
university candidates, they will go back to university.
That's good. That's really good. So you should have just one pathway rather than two parallel pathways.
Okay. Training aside, we have some question actually to Ms. Hashima. It's a question asking actually how soon actually a patient can be allowed orally post esophagectomy. Do you routinely put a NJ or feeding J, Ms. Hashima?
Okay, so personally for my esophagectomy, I do not routinely put a feeding jejunostomy because managing feeding jejunostomy is not very convenient in our setting. Plus, we don't really have a suitable tube to put in, and then there's not, we don't have adequate pump and everything. So instead, we put a nasogastric tube routinely post esophagectomy, and then the feeding can be initiated as early as day 1 post esophagectomy through the nasogastric tube. So we routinely perform the contrast study for the post-esophagectomy between day 5 to day 7 after depend on, because sometimes depend on what time, what day we perform the esophagectomy and what is the next available day for the contrast study to be done. So it's around 5 to 7 days, sometimes a little bit longer. It depends on when is the availability of the contrast study. So if the contrast study shows no leaks, we will slowly introduce oral feeding with the fluid first, and then slowly proceed into the soft diet and orally. So by the time patient is ready to be discharged, they should be actually comfortable taking orally, at least a soft diet. That is probably take around at least 10 days before, post-surgery. Yeah.
Do you think actually, the routine route still will reduce the leak?
Sorry, reduce the leak?
Yeah.
Not really. Basically, the introduction of the NG feeding is just to, we wanted to initiate early feeding. You don't want patient to be attached on the TPN and everything, which will further increase of other possible complications from the parenteral nutrition. So of course, in all, we all into enteral feeding first. So whenever possible, of course, we just gonna put NG feeding first. Rather than just giving patient parenteral nutrition. So parenteral nutrition is really a last resort in our patient, unless they cannot actually give an enteral feeding.
Okay, thank you, Ms. Hashima.
Okay, I think I'm just going to read there are few Q&A question asked in our Zoom chat. Any role of using octreotide in duodenal stump leak?
All right. Okay, duodenal stump leak is a very common complication. The role of octreotide is actually mainly in the first, the first time that we diagnose, when this usually patients, sometimes they can be very septic, the output relatively high. So it's actually helped to introduce octreotide at this time to help to control the contamination. It helped at the time that we are trying to resuscitate the patient in the initial period. So usually, even if we use the octreotide, it's actually work in the first 1 to 2 weeks. That's the most. Beyond that, if your output is still relatively high, it doesn't really serve the function longer than that. That is from what we saw over the years managing this duodenal stump leak. So it really helped in the beginning of the resuscitation period where the leak is significant, you want to catch up with fluid and everything, it does. But use it longer than what necessary is not going to help.
Yeah, I totally agree with you. I myself seldom use octreotide to treat the duodenal stump leak. Yeah.
Honestly, we don't really do, but if somebody want to use it, we actually not routinely practice it longer than, I think the most is 2 weeks. That's the longest that we actually give use octreotide, and it's actually quite expensive to give this octreotide.
Yes, it's not cheap.
It's not cheap.
Yeah. There's one more question directed to Hans. Do you foresee the subspecialty upper GI training to accept private hospital candidate? Because that's what was mentioned by Datuk Kujit recently with our new Minister of Health, not quite new, KJ. There is a plan to the private hospital to train their specialists. So what is your take here, Hans?
So actually, that's a very interesting question. I've not had this question thrown at me yet in any proper meetings, but we had something similar with regards to foreign candidates who want to come and join our program. So there actually is a way for them to apply, but there is a fee that they have to pay to Ministry of Health, and the fee is stipulated year by year. But the actual details have not been finalized yet, to the best of my knowledge. Thus far, we've not had anyone apply to us yet, but I probably will have to get back to you later on. But it would probably be something similar to this, because if private candidates want to join us, they would still have to pay that same similar fee, unless there's some new MOU that is being discussed. In the event of an MOU, then it would be probably a slightly different scenario. So, but this is all still up in the air. I could probably get back to you once I have more information.
Two more questions here. If we have inserted an NG tube and a percutaneous drain in the abscess, what are the indications for endoscopic therapies? I believe it means whenever you have a anastomotic leak and these things are done, how do we decide whether the patient will need endoscopic therapies? Hashima?
All right. Okay, so basically when we have anastomotic leak, by assessment, you already decided what we're going to do. So sometimes if the patient just have radiological leak, for example, that means the leak might be small. Sometimes patient is totally asymptomatic, but your contrast study probably shows some radiological leaks. So this kind of patients, sometimes we actually did our endoscopy and then we see a small leak. Giving it a time, probably it will heal within a week or two. So this kind of patients, sometimes we just gonna leave it. You know, if there is a collection, we're just going to put the percutaneous for drainage. And the reason why we put in the NG in this kind of patient, because we do not want to delay the enteral feeding. So the NG feeding usually inserted to bypass the anastomotic leak so that we can allow patient to have enteral feeding while allowing the leak to heal by itself. But let's say, for example, you see leak is slightly bigger, and probably a patient that you think that will not tolerate the NG feeding as much, because not everybody will like to have an NG feeding. So by inserting, for example, let's say with you think you can actually clip, or you can actually put a stand. By clipping the leak, it will probably allow the faster closure of the leak. And then thus you can actually allow the patient orally relatively faster. And the same thing with the stand. Some patient might not like to have the NG tube for 1 or 2 weeks there. They might want to go back earlier. So putting a stand that will allow us to introduce orally a little bit earlier so that the patient can actually be discharged earlier. If they doesn't require any drainage, or even if the patient have percutaneous drainage and drainage is not so significant, patient is nearby, sometimes we can actually discharge the patient with the percutaneous drainage home to be reviewed as outpatients. And then we decided then when we want to take out the drain. So this is in some time that how do we decide? In general, the small leak we don't really, because stand itself is not cheap. Okay, so you have to think which is more convenient, cost effective. So a lot of things that we have to think while choosing what is the most suitable intervention for the patient. Yeah.
Okay, probably it's time for us actually to take a last question, maybe open to all the speaker. Any specific advice to patients post esophagectomy, so that actually can actually reduce actually the chances of leak?
Okay, I think I shall take the one first, then you all can continue. I think it's a bit difficult to put the blame on the patient. I mean, we can actually advise the patient to avoid other complication, because other commonest complication related to esophagectomy is a pulmonary complication, and other related that you have to encourage patient to, you know, mobilize early and everything. But if you were to put the blame whether the patient can develop a leaks, I think is most of it is our doing, the surgeon doing, and our fluid management, all this technical thing. Other than that, even if the patient have you know, malnutrition, or patient have other underlying comorbid, it's up to us who is actually the one who should monitor and manage the patient. So just our mainly advice is to have them, you know, mobilize early, their, you know, incentive spirometry to avoid the other potential complication related to esophagectomy. That's my opinion.
Can I add on a bit?
Yeah.
Normally, when I want to schedule any big surgery, especially in upper GI surgery, be it esophagectomy, gastrectomy, or whatever, so we give a bit of time for the patient to get prepared. Obviously, we normally don't schedule the next few days. So at least a week, 2 weeks for that patient to get prepared. So the example I normally give them is that they're going for a competition. They're going for a marathon. Okay, so there are two things that's most important. Number one is nutrition. They have to eat well. Number two, they have to build up their stamina. Just like Lee Chong-wei going for a badminton Thomas Cup or whatever. Let's say their competition 2 weeks ahead. So Lee Chong-wei will have to have a specific diet. He has to train himself so that he peak in 2 weeks' time. So that's the advice I normally give the patient. So you need to peak. Your body condition have to peak during the surgery. This is what you need to do. You need to see a dietitian, you need to eat well, and so on. You need to start exercising now If you can't run, you can't jog for 5 kilometers, at least you go out and you have a walk for half an hour, obviously in company with somebody and so on. That is how I advise them to laymen. That's my opinion.
Yeah, I totally agree with both of you. I think prehabilitation is certainly the key when we prepare for any major surgery. So there are 3 axes here, as Mr. Yap has mentioned: nutrition, physical fitness, mental preparation. You got to prepare them mentally, proper counseling, go through with the patient and the family about the course of treatment and what to expect after the surgery. And I think whether to leak or not, always it comes to 3 factors as well: patient factor, disease factor, and surgical factor. So patient factor, we got to prehabilitate them well, nutritionally well-nourished, physically fit, all right? And then also mentally prepared, then we subject them for surgery. And when we do the surgery, probably tension-free and good blood supply is always the key to have a good anastomosis to reduce the chance of leakage. And of course, we try to reduce any risk of, for example, recurrent laryngeal nerve injury that leads to hoarseness and aspiration pneumonia, because we know that this is a vicious cycle. Whenever there's a hoarseness, aspiration pneumonia, patient go into infection and then compromised blood supply because of septic shock, and then there is an increased risk of leak or gastric conduit ischemia. Okay, yep, that is my opinion. Anything else? Yeah, sorry, yeah.
Hans, any comment?
I thought you were going to wrap up. Yeah, I just, a small little note, stop smoking.
Yeah,
yes, that's important.
Yes, those 2 things. But other than that, you've got everything already.
Okay. All right. I think we have come to the end.
Can I just add a small little note?
Yes.
Yeah.
Go on.
Looking, hearing your presentation, Kelvin and Waikiat, it really brings back some memory in a lot of people who have undergone fellowship overseas. What I want to stress here is, most of us are adult here. In fact, all of us are adult here. The best time in our life so far is when we were student. We don't have to think so much. No hassle. Not much of responsibility when we were student, went to school and so on. So during training, is also, to be honest, some of the trainees probably will feel that is the most stressful part. But actually, when you become consultant, you will realize that when you are trainee, when you're a fellow, that was the best time in your career. And fellowship is probably one of the best time in your life. Everybody have their own best memory. Okay, this is just one the thing that I want to mention. Okay, you might think that you suffer the most now. When you become a consultant, you probably feel that, I prefer being a trainee or fellow all the time. That just to add to what Vijay said.
Yeah, certainly. I think the 1 year abroad certainly is the once in a lifetime experience, and probably one of the best time during our career.
I totally agree. Totally agree.
Yeah.
I enjoyed the same.
Yeah. Okay.
Hans, if your fellows are watching this webinar, I'm quite sure they're going to see all your fellows going to either east or west. So Kelvin and Uy, you better warn your professors both in Shanghai and Erasmus that you're going to get a flood of fellows coming from Malaysia.
And also, I'm sure just like Kelvin mentioned, I did my fellowship at Edinburgh, and now with Brexit, there are going to be a lot of opportunity.
Yes.
For non-EU country trainees from non-EU countries, because as far as I know, they prefer English-speaking trainees from Commonwealth countries to go to UK to work for them with them as well. So there's going to be a lot of opportunity in United Kingdom.
Yes. Actually, there's a website that always advertise the job vacancy. Actually, I can't really remember the website, but there is, I think, something like BMJ job. So every year, there is a certain time of the year, the UK hospital will advertise the post. So whoever interested can just apply, and it is true that the chance of us getting is very high. Yeah.
And the good thing about job in UK is almost certainly, I mean, they are paid job.
Yep.
They are paid job. You can actually you're financial stress free, to be honest, and you can spend quite well there.
Yes, true. Okay, I guess it's 9:45. We have come to the end of a very fruitful session again. So I thank all of you for attending today. Just to an update, we have about 600 registrations for the entire symposium series, and every week we have about 200 to 300 live participants. A big thank you to all of you for the support. And so next week we will have the last session of the entire symposium will be on obesity and bariatric surgery. So please join us at the same time next Friday, 17th December, 7:30 onwards. And an evaluation form will be sent to your email as usual after this symposium. Please kindly give us feedback, either it's positive or negative. Feel free to comment so that we can improve in the future. So before we go, just again, a big thank you to the entire faculty, to our sponsors, and to all participants that are here with us today. Thank you and good night. See you again. Bye-bye.